also an acceptable regimen. So now Sloan has looked at a lot of the literature out there, and there have been a bunch of trials that have said you don't have to treat patients that long. If you compress the treatment, if you squeeze the radiation to a tighter window, that means you give more dose each day, the outcome's the same. So now our long course radiation is 26 treatments. So I'll tell a patient, you've got high-risk disease, you need hormones, yes. If we're doing radiation only, then it's going to be 26 treatments. But 48 or 45 treatments are felt to be equivalent. It's just more of a nuisance because you got to come with it. But that either of those are fine.
Are the 26 treatments?
26 or 48.
Is
That's
that more of a shot?
Yes.
Okay.
Yeah.
And what are the after effects of that?
It's a great question. So, okay, so you're basically comparing. Let's say, so you're basically instead of 5 weeks, instead of like 9 weeks, you're paring it down to like 5 weeks. Let's just say, right? That's what's going on. So what's happening is the dose is getting pushed in more quickly. So patients will complain of the side effects sooner. If I give you 48 treatments, you'll notice essentially nothing for about 2 weeks. You'll say, I feel fine, I don't feel anything. It's after like week 3 that you'll start to say, wow, I'm starting to get more urinary symptoms or like maybe some GI symptoms. If I push the radiation in faster, you notice it after the first week. And when you talk to these patients 3 or 4 months after it's done, they all end up in the same place. They're like, the side effects have cooled off, but the radiation side effects come on more quickly. It makes sense. When you're pushing in the dose faster, you're going to feel the side effects faster. So, 26 shots of radiation, 48 shots of radiation. They're felt to be equivalent. One's just more convenient. Okay. Ascend. This is that Canadian trial that everyone, and it's in the NCCN guidelines. So the reason why the NCCN guidelines put that third option in there, where external beam plus brachy, and then they shorten the course of hormones a little bit, was because of this Canadian study. So what is it? So the Canadians basically, and we've known about this for a long time, they did a randomized trial. They took guys that were high risk, essentially mostly high risk, and they said, okay, we are going to, actually I have a better slide for it. We are going to give half of you radiation without the radioactive seeds, and the other half are giving the radioactive seeds. And so they're basically dividing the work between, part A is stick radioactivity into the prostate directly, and then a month later, give them like 5 weeks of radiation. That's what Gedgerman said, right? Okay.
Well, I think he had the radiation, and then
you do it the other way around.
Yeah.
So the order of events doesn't matter. Our institution does the radioactive implant first, but it really doesn't matter which order you do it in. So these are the results of the trial, and so when the red line essentially represents the group that got the straight radiation. The black line represents the group that got the combo therapy. And here are the results. 3 years, the cure rate was 94%. You're like, that's awesome. I'm there. 5 years, 7 years. When you're almost 10 years out, the cure rates start to go like this. If you get the combo therapy, the cure rates are like 83%, which is pretty darn good for high-risk prostate cancer. That's really good. So when these results were published, it was kind of startling. It was like, wow, that's a huge difference. Because we've known about it though, that there's something that happens when you stick radioactivity right into the prostate. It is more damaging to the cancer. It just is. And so at the beginning, everything looks the same, but when you wait over time, it starts to change. So when we see young people come in here, you're a young guy. You are
67.
Yeah, you're young. If patients are fit, if they want combo therapy, we'll offer it to them. If I see a high risk person that comes in here, then I obviously want to tell them about it. Who would I not push this on? Once you start hitting 80 years old, forget it. No one is going to take someone to the OR. So that's kind of our line in the sand. We're not doing HDR or brachy on someone at that advanced age because there's side effects that are there's these potential complications. Even though it's not really a surgery, I'm going to show you what it looks like in a second. But But if you're below 70, for sure. Because we want a good result, not in 3 years from now, but in 10 years from now. That's what we want. So we want the radiation to stick and hold and just, shut this disease down. Because what happens in these patients, with the external beam alone, it's less likely to completely kill the disease. And then what happens is that, years later it starts to grow back again, and then you have a local recurrence. And there's something that is going on with the brachytherapy that is disallowing that from happening. You do a better job of killing everything. So it would make sense to do yeah, I totally agree with Gedgeman. Yes. Okay. If you did not want that, okay, you're not crazy. I would say that most of the world does not do this. And the reason why they don't do it is because there aren't that many places that do brachytherapy anymore, right? Because if you think about radiation oncology, like, I don't view ourselves as a business because I work for Sloan Kettering and we get salary, but it's kind of an inefficient business model. If you need to take someone to the operating room, it takes hours in there. So radiation oncologists generally don't like to be in the operating room, right? Because it takes away from the efficiency of a day, because things aren't efficient in an operating room ever. I mean, there's always stuff that takes longer, and then it disrupts. So then you have to have, and you have to have special equipment, and there are lots of reasons why this is getting done less and less and less. But at Sloan, we're a huge brachytherapy center. We have 5 people we have 5 doctors in our department that just do prostate brachytherapy. I mean, so we're a huge department that does this all the time. And Gedgeman, thankfully, also is skilled in brachy, right? So that's why he offered it to you. But if you went to a place where the doc didn't know how to do that, he wouldn't even discuss this, because he doesn't want to make you feel bad or whatever. But the truth is, you should hear about it, because if you are high risk and you're fit, then doing brachytherapy just means I'm going to show you how it works in a second, is something to consider.
What are the after effects of that?
Let me show you how it's done. Let me show you a couple pictures. So that's the ASCEND study. Here was a kind of this picture's a little bit better because it's got more details, but it's basically the same thing. I mean, so the bottom line is, actually when they pulled, so in this Canadian study, there were mostly high-risk patients, but there are also some intermediate risk patients, and this purely pulls out all the intermediate risk patients, so it's only high risk. And the results are at 9 years, the cure rates are 78% if you're only high risk. Yeah. And it's about 58% if you get, so the other way to look at it is, look, even if you did external beam radiation and no brachy, there's a good chance you'd be cured. But chances are better with combo. Okay, so let me show you how it's done. Okay, I got a couple pictures here. I'll show you just how that procedure is done, okay? And then I have other pictures for the external beam part. But so there are 2 basic ways of doing radioactive seeds, okay? There is something called LDR and HDR. LDR is when you actually take radioactive seeds. They're about they're about pencil lead thin. That's it. They're tiny. They're on a penny. You could put a bunch of them, right? You put a bunch of seeds into the prostate, and then you're actually radioactive for, maybe several months, okay? And then you don't want children sitting on your lap, or babies, or whatever, or pregnant women in your close proximity. That's one way. Then there's another way called HDR. They're both felt to be equivalent. So it really doesn't matter which one you go with. You're going to go with what the brachytherapy doc is most comfortable with. So Gedgeman, I don't know what he told you, but he either said, well, I'll give you I'm going to give you these, 25 treatments or whatever, and then, a few weeks later, we're going to do the procedure, and you're going to be operating room for 2 or 3 hours. I'm going to put in these radioactive seeds, and that's going to be like the part B of the radiation, something like that. The other way to do it is with HDR, and again, these techniques or the outcome is felt to be the same. If you look at the Canadian study that I just showed you, they did LDR. They did essentially what Gedgeman might have told you. At this institution, we do it usually with HDR. So
he did say HDR.
Oh, good.
Also. Yeah.
He's doing it. Okay, then he's going to do it this way. Perfect. Okay, so then it'll be in line with what he told you. Okay, so if you do HDR, so you got to be a little bit careful. And we do not think there's any difference in terms of LDR and HDR. So it kind of doesn't matter which way you do it. And the Canadians did it with LDR. They did it like kind of more of the traditional way. Okay, what's HDR? They put you to sleep for it's about a 3-hour gig, something like that. They're going to put a bunch of needles into the prostate. Okay, and they're hollow. They're hollow needles, and once they're in there, then software is basically going to, they run a program that tells the computer, look, you're going to hook this robotic. It's not really a robot, but it has a little bit of a robotic look to it because there's a radioactive source inside this machine that's attached to a guide wire. So the radioactive source can't like fall out. It's attached to a wire, the tip of a wire, right? And it's going to get pushed out through one of these catheters, through one of these tubes, right along it, and it gets pushed right into the prostate. Shoot. And it's going to sit in that part of the prostate for like, 27 seconds. And the computer's going to pull it back a little bit, leave it there for like 17 seconds. It's going to pull it back a little bit, for X number of seconds. Back, and it's going to pull it out all the way back in the machine and then into the next tube. And they systematically irradiate the whole prostate, within like, 20 or 30 minutes. It's all done. And then the radioactive source goes back into that robot, into that machine. And so you're not radioactive anymore. So the cool thing about HDR is there's no radioactivity and then they pull everything out and they wake you up. And then you're no longer radioactive. So the difference between HDR and LDR, the way the Canadians did it, is that you don't have any radioactivity inside of you.
So in other words, the HDR is a 3-hour session.
Yeah.
And I'm done?
Yeah.
Oh, okay.
Yeah, because the way that he said it was that he'd be staying overnight in the hospital and that he'd just be getting like an epidural.
Yeah. So there's different. Okay. Each institution has different ways of doing this. So we used to do that here. Now we do it all in one. So basically, you roll in. It's an operating room. Then the anesthesiologist is going to come in and say, Mr. So-and-so, you're here today, for HDR. Then the brachytherapy guy comes in and says, we're going to do this and this and this. Then they knock you out. They put you to sleep. They put your legs up in a stirrup. Then they put those needles in. Then they do the software calculates what it needs to tell the HDR unit, how to place the radioactive, source in the prostate. Then that gets done. Then that thing goes back into the machine. Then the crew walks back in. Then they pull everything out, stitch whatever they need to. Then you wake up with a Foley. You're gonna have a Foley in, but the catheter to the penis. And at the end of the day, in the evening, before they send you home, that Foley comes out and you have to pee. And as soon as you can pee under your own power, you go home. That's how it works. So they try not to keep patients in the hospital anymore.
Okay.
But still though, like, Gedgeman, he's going to do this at Hackensack or whatever. He's got a way of doing it. He has to. Like, every doctor has to have a system that works, and that's fine. I mean, he's keeping you over one night. All right. When this started, it used to be two nights in the hospital, and it was miserable for patients because then they had to be up in stirrups and all this stuff. But the technology's moved along, so it's much better now. Things have moved along, and these companies have made it easier for everyone. So it takes industry, it takes institutions to, so. Gedgeman's going to do it a certain way, and he has to. I mean, that's what he's used to doing, and that's all that really matters. So but if he's pushing that, I'm for it. I'm like, yes, that would be, I would favor that for a young person with like high risk disease. If you didn't want it, I'd say, okay, that's okay. Then you get hormonal therapy and external beam. It's either 9 weeks or like 26 treatments. And the outcome is you can't say that one's better than the other. They're fine. Either is fine.
Okay.
That's what I would tell you.
Okay.
So, okay, that's HDR. And there are, Okay, let's say that, so here, they'll do the HDR first. Okay, so let's say that you get your HDR and it's, it's like March the 1st, whatever, or February 15th, whatever date that is. Okay. You go home that day. 2 weeks later, we need to design the radiation field for part B, which is the 5 weeks, or it would be 5 weeks. Okay. All right. So you have one operating room procedure, which we just talked about. 2 weeks later, we need to design the radiation field for the radiation that will, like, for instance, happen here. Okay. So this guy had the HDR done 2 weeks before, and they brought him back, and they're making a mold because we need to now design the radiation field for the 25 shots of radiation that he's going to get 2 weeks after this. So there's like, if the HDR happens on March the 1st, the radiation will start April the 1st. About a month later, it's a month gap in between the two procedures typically. And in the middle, we need to design his radiation field. So HDR procedure, 2 weeks later, map the patient, 2 weeks later, start the radiation.
When you say map the patient,
Yep.
is there any, like, do you have to go inside and do anything? It's just-
No. So a couple things. Logistics. HDR happens in New York. Happens in Manhattan, right? So you need an operating room, and we don't have that in this building. So just so, like, if this gets done at Sloan, then one of our Brady guys will do it. We have 5 of them that do this, and you have to meet with them first. Then they're like, okay, sounds like a good plan. They're gonna book an appointment for HDR on a certain day. You have to have pre-op testing, right? It's an OR procedure which would happen typically here, but just in terms of, like, oh my God, how many appointments is this? That's what it is. Then once the HDR is done, 2 weeks later, you got to go back in Manhattan to get this done. Why? Because we're doing another MRI. You might say, my God, I just had an MRI. Why do you need to do another MRI? It's because your anatomy's changed a little bit. They put a bunch of needles in there, and things can be more swollen. So depending on which order you do the procedure, so this mapping then, of course, has to occur after you have the implant done, and we have to rescan you because we want to make sure everything is right on the money, right? So this guy went back into New York, they made a mold, and they did an MRI, okay? And then I designed the radiation field, and then 2 weeks later he starts the radiation.
Here.
Okay, so that's what the machine looks like. It's it's a linear accelerator. It's a high, state-of-the-art radiation machine, whatever. But it's going to basically treat what? Well, we put a bunch of needles into the prostate to cook the prostate, give it a big dose of radiation. Now, if this is a side view, prostate's down there. Front view, prostate's that. But look at the radiation field. I'm not just treating that area there. The radiation field swings out up here on both sides. I'm getting the lymph nodes too. So when we treat high risk, I'm treating not just the prostate but the lymph nodes too. That's all in the radiation field. So when people ask me, what kind of side effects am I going to get? I'm like, well, look at the picture. Here's a side view. There's the bladder, that white thing, prostate's there. So are you going to get urinary symptoms? Yeah. Urinary symptoms are more frequent urination, mild burning with urination, and remember, this is now happening a month after the HDR. So the HDR, they put a bunch of needles in there which causes swelling. So when you go home that night of the HDR, they're going to give you Flomax. So your urethra is more relaxed and you can pee easier. And then over about a month, the swelling cools off, but now I'm going to start giving you radiation so the side effects can ramp up again, right? So urinary side effects are common, but they're managed, typically with like Flomax, even Advil, like those types of things. What about, rectal irritation? Am I going to give you rectal irritation? Probably a little bit. It's usually not too bad. Are we going to put in a rectal spacer?
Yeah.
Right? We often do. When do they do it? if they're gonna put it in, they're gonna put it in at the time of the HDR, right? Because you're asleep anyway. You're gonna put in, and they'll put in 3 gold Cs in the prostate too. It all gets done in that OR slot. Why wouldn't they do that? They've got you on the table, you're asleep, and so they'll do it at the end. Sometimes they don't put it in a spacer. It depends. It depends on what the MRI that I'm recommending now shows. They want to make sure there's no cancer going back through the shell of the prostate, or they want to see all that first. But yes, do we do a spacer? We often do, but it depends on, so, and when that happens, it would happen at the time of the HDR procedure.
Okay.
Okay.
You don't want the HDR.
Don't want it? Okay, great question. No, it's fine. This all needs to be discussed. Because sometimes you get an MRI, and you're like, oh my God, we can't, so, and sometimes patients don't want it, sometimes patients aren't physically fit enough, or, you've got a guy with a pacemaker, defibrillator, they're on blood thinners. There's lots of reasons why patients just simply can't do HDR, or maybe they don't want it. Then you take out the procedure out of the picture completely, and then you're like, okay, you already started the hormones, great. Over the probably in a couple more weeks, because what's going to happen on the hormones, your prostate's going to shrink. It's going to shrink by about 30% in size, and pretty quickly. So it starts to kind of shrink a little bit, which is good. Often patients, when they start the hormones, their urinary symptoms get a little bit better, because they're like, wow, my prostate's shrinking. They don't know that the prostate's shrinking, but they'll say, I'm peeing easier. And I'm like, that's because the hormones. They're shrinking up your prostate immediately. But if you didn't do the HDR, they have to put in fiducial markers in a rectal spacer, right? I'm going to show you what that. Do you see a picture of what that looks like? Let me show you a quick picture.
No.
It's real quick. Show you. Yeah, spacer. It's a gel. That's all it is.
Oh.
Basically, they take a gel. They knock you out for like 15 minutes, right? They take a gel, long needle, and basically inject it in between your prostate and your rectum, and it solidifies in 10 seconds. Really fast, boom. And then it fixes, and then it sits there for at least 3 months, probably more like 6 to 9 months. But it's supposed to stay there and not budge for 3 months.
Mm-hmm.
And then it's water soluble, so then it dissolves on its own, and you don't really feel much. Usually, some guys might feel a little bit of pressure right after the procedure, but then they don't notice it. It doesn't and you don't have any bowel movement problems or anything like that. So then, same procedure, 3 seeds, boom, boom, boom. You can think of this as the GPS system.
Why 3? Why not 4?
3 is all you need for to target, to find the location, to nail down the location. But you actually only need 2, but 3 is better.
Mm-hmm.
So 3 is a standard. It's a standard.
Okay.
2, you can do 2 though. Some places still do 2, but 3 is our standard.
Okay, and when you put them in, I'm knocked out?
Yeah.
Or about
They
how
do
long?
the spacer and the seats at the same time.
Okay, how
15
long am I?
minutes.
15 minutes?
Yeah.
Okay.
Yeah, it's kind of like a colonoscopy.
It's not bad. It's really not bad. And they don't want you driving that day. If you get it done here, you gotta go to Manhattan to get it done. It's the same guys that do the brachy do this too. They have one day where they just do seats and spacers. So, but they want, anyway. Yeah. So if you're not doing the brachy, then fine. Typically seats and spacers. I'm sure Gedge would tell you the same thing.
Yes.
Okay.
That's pretty much it. I mean, so remember, you've got a curable problem. It's not the end of the world. I'm sure that's what they told you there too. You're young, so we're gonna want to be more aggressive. It's so hormonal therapy. The minimum would be 1.5 years, but more commonly they're going to say 2 to 3. That's what everybody says. The radiation needs to include the pelvic lymph nodes, right? So we're not just treating the prostate. When we treat the pelvic lymph nodes, I didn't tell you this, you're more likely to get diarrhea because the radiation field you saw goes higher up. There's more intestine up there. So if you get diarrhea, stay away from dairy products. No milk, no cheese, no yogurt, no ice cream. Take the soy and almond milk, or whatever. Just stay away from dairy. It's simple follow, rules follow. And then if you get bad diarrhea, take Imodium. Okay, it goes away a couple weeks after you finish Zolgone. And that's
Now, what happens down the road?
Yeah.
God forbid, but it could happen that the cancer comes back.
right. So it depends how it comes back. But, so if you don't kill everything in the prostate, let's just say, that's like one scenario is, look, you know, and you saw in that, some of those images, like sometimes the radiation doesn't completely destroy it, and it, let's just say it hasn't spread, it's only in the prostate. So classically they'll say, well, you can get it cut out, you can get the prostate removed. The problem with that is there's a lot of scar tissue down there now.
Mm-hmm.
And so the risk of incontinence is really high. And historically, 50 to 60%. I've seen these patients, you've been doing this long enough, you will have patients that will fail. It's not common, but if it does happen, you gotta cure the patient. So, you know, and these patients often have incontinence. They have leakage permanently, right? After, and that's not fun, but they're glad to be alive, you know. Now, what we're trying to do is to not do that, and we try to pinpoint where in the prostate the cancer isn't dead yet. So what they'll do is they'll MRI and rebiopsy that and try to figure out if it's in a certain area. They'll put radioactive seeds in there, and the salvage rate's about 50 to 70% with that. So that's one way of avoiding like a salvage surgery. Okay. What if it spreads, or what if it's somewhere else? Then it's hormonal therapy. They're going to put you on, you know, like Lupron or one of these other drugs I showed you.
For how long?
Indefinitely. But I look, you know, we can only deal with the army that we have now. In the, you know, we say in the future things are going to change. They're going to change. I mean, you know, we're going to.
Mm-hmm.
It's just the cancer is moving at such a fast clip now. And you know, immunotherapy is now on the scene. They're starting to do some immunotherapy with prostate cancer where it's spread, but they haven't had the same success yet. But that for other types of cancers, but it's going to completely change. In 10 years, it will be, I think, largely unrecognizable what we're doing now. No. So, I mean, right now, it's all about curing you. That's what we want to do. That's all. And we want to hit this with hormonal therapy. You started it, so you can actually kind of relax now because this cancer is going nowhere. So you're killing cancer cells right now. There's true. If you were to get an MRI about 2 or 3 months after the hormones, the prostate will shrink and the tumors will start to shrivel up in there too. So you can relax. You're okay.
Well, let me ask you something. Rather than all this, why didn't they just give the shots indefinitely?
Because it won't kill it completely. What happens is you'll get resistance to the hormone after a couple of years.
Mhm.
Yeah, and then you'll actually get a nastier cancer. It'll get nasty. So you have to just, you know, typically you wait. Sometimes, you know, patients have like a huge prostate. You really just want to shrink it. You wait 6 months before you start the radiation. You could wait that long, sometimes even longer. But standard is 2 to 3 months.
Okay.
So yeah, you get the radiation going. You know, Gedgerman's going to tell you. He's going to say, he probably said, look, with 2 to 3 months, I want to start this external beam. Then we're going to do the implant. Fine.
Okay.
That's what I would lean towards. But external beam alone is fine.
It is. Because I know that's what he
That's what
what
you
he
want.
wants.
Kind of freaking you out to have to go to the OR.
Yeah, and go all the way to New York and go.
Yeah, but no, I
my
even mean with
God,
Gedgerman.
It's an ordeal.
It is, yeah. But even with Gedgerman, I mean, you know.
Yeah, that was freaking him out even with that.
freaking
yeah,
out.
This sounds better. I was gonna
Well,
do it.
but
I
still though,
would do
maybe sometimes you just have to sit down with them again. Say, look, can you just tell me exactly? Can you know? Sometimes it's helpful just to have them sit you down again. Say, can I meet with you again? Can you go over this with me again? Can you show me pictures? He has all that stuff. Yeah. So, bottom line. So no matter what, you're in a safe place now. You're okay. You're on the hormones. This is going nowhere. Yeah. And you've got, you know, 2 to 3 months from now, so you start the radiation, right?
Yeah.
Yeah. Yeah.
Okay.
So you really don't think that I mean, if he
Yeah.
doesn't do the HDR, that
Yeah, I mean,
they would just do the radiation for longer.
most places in the country, they won't do the HDR. Why? Because lots of places can't do it. They don't have the training. You know, they don't have the manpower. Here, like, look, we've got a big Breaky program, so we're very like Breaky. You know, we promote it whenever we can. Not because we believe in it, but it's not wrong to say no. I don't want to do that because most places would just give you external beam alone, and either doing it over like 9-weeker is fine. Here we tend to Some guys still want 9 weeks, so I've got a couple of guys here, I'm doing 9 weeks, even though most of my department does. And that's our standard, is to do 26, but if they requested it, we'll do 9 weeks. I treated patients for years with that regimen, and it works. It's fine.
Okay.
Yeah, it works. Okay?
Okay,
All right.
thank you.
I hope I haven't bored you.
No.
I
lots of
just want to make
information.
sure that, look, when people come here, I feel like I'm not gonna spend 5 minutes with you. I'm gonna give you the time that is warranted. If you don't want it, it's fine, but otherwise, like, why would you, you're spending a lot of money and stuff like this. I don't want you to feel like I'm just, brushing things off. I'm not. I mean everything I say. We've got booklets on HDR. If you want, I can give them to you. So Sloan County prints these things out. They're general. They're good information for wherever you're getting the procedure done. I'll just give it to you. You're here.
Okay,
Okay?
yeah.
Pretty much
Yeah.
it.
Well, I think they know what you're gonna do.
Procedures.
Oh
Kidding me?
my
Oh
God,
my God,
Art.
it's a long line of procedures. It's not like, I wouldn't start saying that. I'm saying, yeah, I might do that. Go there for 3 hours. But don't go to
Right,
New
he's
York,
gonna
you
give us,
gotta
he's
get.
gonna give us, oh, okay.